Welcome to a special episode of the Indian Journal of Anesthesia podcast. Today, we have the privilege of having a giant in the field of anesthesiology with us, Professor Adrian Gelb. From his early days in rural South Africa to becoming a distinguished professor at the University of California, San Francisco, and being the president of the World Federation of Society of Anesthesiologists, Dr. Gelb has been a transformative force in our specialty. His CV runs into 100 pages plus with over 350 publications and a lot of work in neuro anesthesia and a deep commitment to the global health equity. He has shaped both clinical practice and policy in our specialty. His special connection from India spans more than 3 decades, and he's been giving lectures, orations in India for this amount of time, shaping the entire landscape of anesthesia in the Asia and Pacific. Dr. Gelb's vision of safe anesthesia for all has influenced WHO guidelines and standards and impacted thousands, if not millions of lives. As someone who has trained generations of anesthesiologists worldwide and fostered worldwide collaboration, particularly in the Asia-Pacific region, his insights are especially relevant to our audience today. Welcome to the show, Professor Gelb. It's wonderful to have you with us.
And I'm thrilled to be here. I'm thrilled to be back in India again.
So we will start with our conversation with a little bit of personal journey. Can you just tell us briefly about what made you move from South Africa to Canada, to the US, and later to all these leadership roles at global organizations?
There are really two separate issues. One was the moving, and the other is taking on roles. In relation to moving, like many of my classmates graduating in South Africa at the time, we saw no good political future. We didn't support the way the country was governed, the direction was taken, didn't imagine that it would change fundamentally. So it was really a decision based on politics more than anything else. It was sad to leave family behind, but progressively my brother moved, my sister moved, and we moved from being a Southern Hemisphere family to a Northern Hemisphere family. We liked the notion of Canada. The UK, even back then, seemed to be in decline in many ways. We didn't want to be Americans, and Canada appealed because it was a softer country, a gentler country than the United States, and had a political system we could understand with the old British parliamentary system. The move from Canada to San Francisco came about because I found myself, much to my amazement, the department chair in my Canadian university at the age of 39. 12 years later, I thought there's more to life than being a department chair, although I learned a lot in the role. And I'd come to have a reasonably close working relationship with Ronald Miller, who was the chair at UCSF, through a variety of organizations, travel, and the like. And he started saying to me, Adrian, come and be my vice chairman. And so eventually I agreed. San Francisco is a wonderful city. It's a very livable city. It's a culturally rich city. And our department at the University of California, San Francisco is one of the global leaders in anesthesia, from molecular biology to clinical science. So
we will definitely come to the research in a bit.
Okay.
But again, taking the personal journey into the perspective, any experiences from early career that still continue to influence you today?
I would go back even before early career. My parents clearly at a point in their lives had difficulty finding employment that was comfortable. So in the space of about 2.5 years, I went to 5 schools. I came to understand what it was to be the new kid, to be the lonely kid, what it was like to be the picked upon kid because you were new. And I was also a very chubby kid, the fat guy. And so it gave me a tremendous sympathy with the underdog. Throughout my career, I instinctively leaned towards who needs help, who needs somebody standing next to them. In terms of the leadership roles, my teachers in high school pushed me into leadership roles. You know, they would say to me, Adrian, you should apply to be, you know, the chairman of our, you know, academic
Arts club or
whatever,
yeah,
various
club,
things. And I guess maybe I was just an obliging student. My parents encouraged me, and I took on those roles, and it created a pattern of realizing the reality that 90% of success really is showing up.
Very true.
But it's not just showing up, it's agreeing to do the work that comes from showing up. So if you're willing to put your hand up and say, I want to join that group, you need to commit to say, I will do something while I'm there. And once I got that clear in my head, the rest seemed to just follow along.
Now, there is a quote, I don't remember who wrote it, but it said that what you focus on is what your reality will be tomorrow. And your focus has been on research. And with more than 350 publications, you have shaped the clinical practice of anesthetists across the globe. Are there any papers that come on top of your mind which have shaped clinical practice in a very big way? The ones which you have done research on?
That's a really difficult question.
I know out of 350 to pick a few is difficult, but
yes, it would probably be easier to say which were the papers that shaped me, because judging how clinical practice has changed, I'd be hard pressed to say this paper had documentary evidence for impacting clinical practice. I think throughout the arc of my research, it's been driven by clinical questions, things I've thought about in the operating room. And one of the sad things that I find is children, by and large, are naturally curious. And we beat that out of them in the school system. We regiment them. And what we need to do is to reignite that. And in my medical school career, I started learning that asking a question and saying, that doesn't really make sense to me, was quite legitimate. So in terms of which papers do I think were important, I think playing it backwards, I think the international standards for safe practice of anesthesia have been very influential. Not that there are many countries that have necessarily embraced the whole. There are a few. The Ministry of Health in Mongolia, for example, adopted them as aspirational. In Eastern Europe and Romania, the same. But I think that they've had an impact in forcing some national societies in low or lower middle income countries to say, hang on, we should see if our standards that we've made meet these standards, what's missing. So I think it's been a pretty influential paper. In neuroanesthesia, probably 2 clinical trials that I was engaged in. One was the cerebral aneurysm hypothermia trial, showing that hypothermia didn't improve outcome, was important. And the other was a study I did demonstrating that hyperventilation, reducing CO2, actually improves operating condition. There was, and is a lot of literature on ICP and CO2. Once you lift the bone flap off and open the dura, the ICP is ambient.
The perfusion pressure doesn't.
And the key issue then is operating conditions. Is your surgeon happy?
Is the brain relaxed?
Exactly. And so that brain relaxation versus ICP is important. I don't know how influential the publication is that's in the BJA, where we actually discuss the difference between brain relaxation, in brackets, surgeon happiness, and ICP. But conceptually, I think it's an important framework.
And in your career, you're seeing that most of the easy pickings in research have already been done. That is, a lot of big questions have been answered. So for young researchers listening to this podcast, what's your guidance on where they should be focusing their energy, their curiosity, if you want to call it, in the future research, more questions that they have?
Starts in the operating room at the bedside. And you, in those long days that you viewed as boring days, start asking yourself, what is the justification for the practice that I've just done? Is there evidence to support that? Does it make sense? Should we be doing this? Should I be studying this? There's an enormous amount of clinical practice that is not really evidence-based. You can look at almost any Cochrane review of anesthetic practice, they're inconclusive. So all of the questions haven't been answered effectively. So there are lots of questions that one could think about. Answering them is a different challenge, and maybe that's something we want to discuss separately, which is what skills do you need to actually do the research? But the opportunities and the questions are at the bedside if you focus your mind on why do we do this?
Now, as a clinician, if somebody were to think about doing research, there are a lot of barriers to start doing research, asking the right question, or conducting an entire study. Is there anything, having been the president of the World Federation, that you have seen would help such scenarios where people who are clinicians, active clinicians, can do research? And is there anything that the global societies can do to help such alleviate these barriers?
That's a very good question. The short answer is no. Most global societies don't have the budget to train people. I think what many do not understand is that the requirements of research these days, of funded research, is a whole separate fellowship. In the old days, in my youth, and before, you did a little study of 20 of my own patients, with a twitch monitor, without a twitch monitor, who breathed better at the end. Those days are long gone. And so the skills necessary to do meaningful research are an order of magnitude different. And in order to acquire those skills, you actually need a 1 or 2 year commitment to acquire those skills. And that does cost money. And I can't think of an agency that has that money short of applying for a national grant, for example, specifically for research training. In anesthesia, there are not a lot. One would need to view the anesthesia study in a broader epidemiological sense and build a case for it. But most meaningful research requires training. Are there short options? Yes, you could do a course fairly easily in how to do a meta-analysis, and then partner appropriately with somebody who can help you with that. I don't know in India, but certainly in Western Europe, in North America, libraries now offer those services. Statistical departments also offer those services, but they're often cheaper and easier through one's library, where for a nominal fee or a co-authorship, the librarian will run your literature search for you. So I think that type of research could probably be done with less training.
And what about the role of multi-center trials or multi-center networks? Now, you've been coming to India for the past 3 decades. Have you seen a change in the research landscape here? And any advice to the young researchers or even bigger institutions as to how they can collaborate together for multi-center network studies or something on those lines?
My impression, and I'm open to correction, but from the major journals I scan over every month, I would say Indian anesthesia research has fallen way behind. I see almost no large multi-center studies coming out of the Indian anesthesia community. I see no move by any agency to do things like create a biobank for perioperative care. That would involve investment from a state government, probably some philanthropic organization. But I used to travel frequently to China as well, and I think they've pulled way ahead. They invested heavily from the National Anesthesia Society and beyond in initially molecular biology research, because it was relatively easy to send somebody to work in a laboratory rather than in clinical activity. And I'd say over the last decade, they've made huge efforts to build multi-center consortium to capitalize on the large patient populations they have. I don't see the same here. And you have large patient populations.
We do.
And it worries me for the future of anesthesia here, not just because you're falling behind in some kind of race, but we all talk about AI and how AI is going to revolutionize care. AI will only be as good as the data that goes into doing those algorithms. And if there's no Indian data, you're going to be practicing on AI models developed in the United States, developed in China, developed in Western Europe. And I don't believe that's in the best interest of the Indian population.
That's a wake-up call, a message to all the young researchers. And moving on to your leadership roles and what you learned, I believe you were the president of the World Federation when COVID visited us. And I'm sure there are a lot of learnings during that phase. Anything that you would like to highlight as a leader that you went through, the lessons that you learned during that phase?
Perhaps the biggest lesson, which is a lesson of life in general, is the future is totally unpredictable. And you never quite know whether you're the department head or you're leading a multinational organization or you're in government on what exactly you're going to be challenged with. It was a very difficult time for us as an organization. We had to deal with operationally within the WFSA that our small secretariat, 10 people, worked from home. Cash flow essentially disappeared. The projects that we were funded to do, we could no longer do. So the cash didn't come in the door. So we had people who were working half-time. And we also had to adapt on what was our role in COVID. There were so many organizations doing things around the perioperative space, a little more focused on critical care than operative care. And so we found that our role was really in education, in setting some recommendations and guidelines, trying to consolidate information of value. But it really did require a quick rethink on what can we do in a circumstance we initially didn't quite understand what we were dealing with.
My question again is on leadership. Now, is there a personal philosophy that you go by for leadership, and you are dealing with people from different cultural contexts? How do you go about being a good leader?
Listen, understand, read, if necessary, about other cultures. I mean, there's some simple guides out there. One of the ones that I liked when it first came out, probably 25, 30 years ago, Kiss, Bow, or Shake Hands. They've now turned it into a big series. But it covers simple things about a society, national holidays, common practices. Is this a society that's where people are always on time or early? Or is this a society where everybody's late, for example? So you can pick up some sense of the culture. So in Mexico, if you're not an hour late, you're being rude. You're showing up your host. In Japan, if you're not early, you're insulting your host. So you can read about those things to understand the culture. In terms of how to work with people, listen to their discussion on an issue, trying to promote capnography or pulse oximetry or medication safety, and then work within the confines of their context. What can their health system achieve? And if you're in a leadership role, how can you use that leadership role to bring in the enablers, the collaborators? Do you have any connections to surgical leadership? So I think about those aspects. Who can I connect with? Who do I know? If we're talking about India, is there anybody that I've connected with at the World Health Organization who could potentially help and say, oh, yes, this is somebody we work with in the Ministry of Health. Yeah. I can make the connections. I can't force the interaction.
Very true. Very true. And building consensus amongst different stakeholders, any points there that people can take home?
So consensus, in my view, is 51%. You will never have 100% agreement. Rarely, very rare. And I don't think it's what one needs to aspire to. You need to understand in any group what would be a reasonably acceptable compromise, consensus. And you need to give some thought to who am I going to lose in this process. So you need to know who's on your side, but you also know who is not going to be on your side and whether that's a worthwhile sacrifice.
Now we'll move a little bit to the World Health Organization, your efforts there, and we'll touch upon the Lancet Commission and the disparities that it showed across the world when it comes to delivery of safe surgeries. Is there anything an individual can do? This is a difficult question, but I'm not talking at an organization or a country level, but is there anything an individual can do to decrease this disparity or help in improving safe surgery across the world? For people listening, they might be listening across the world to this podcast.
Absolutely. If you think in a military concept, an army needs every soldier at every rank. We can't all be generals.
Yeah.
And a general is useless without the individual soldier. So I think your question is right on. One can influence one's own practice. and the practice of one's colleagues and the practice in your own hospital. So clean your own house is something all of us can volunteer to do. And I emphasize that volunteer.
Yeah.
It's uncommon that one will be paid to do the right thing in one's own institution or another. Are there things that one can do more generally? We tend to think of global health as an issue over there, some other country. We forget their needs in our own backyard. So one doesn't have to go far to say, I'm going to help in some underserviced area. And that may be an underserviced hospital in Mumbai that serves the Dharavi population, for example. Or it could be, I'm going to take a week of my allocated holiday and I'm going to work in Orissa or Bihar or some poor state.
Yeah.
So you don't have to travel far. In doing that, you need to think carefully about what you're going to do. And what one needs to do there isn't displace the local providers, is to work with them, understand their challenges,
Empower them.
and then empower them and teach them a better way of delivering care. So yes, it's within the ability of every one of us to make a difference.
Now, as anesthetists who are listening to this podcast, many of them might be playing the role of somebody behind the screens because the surgeon takes the limelight when it comes to the surgical practice. But you've been at the forefront of the World Health Organization shaping standards, policies. Can you just tell us a little bit about your experience in the WHO and how, as an anesthetist, you are sitting at the table, shaping the global standards and policies? How did it feel like? And is there anything as a message that you would like to tell the anesthetists?
Well, as you have probably gathered, I'm not shy about speaking up any longer. I used to be very, very shy. And I decided a long time ago, in my early days of leadership within the department, if you're going to deal with surgeons, they understand other surgeons and you need to speak the same way.
Yeah.
To a large extent. The WHO is a very cumbersome bureaucracy, like government.
Yeah.
They run on a shoestring budget. There's not actually a huge amount they can do, or they can't do all of the things one would like them to do. And they're very dependent on volunteers. In terms of delivering the anesthesia message, I think the message is understood and valued in the group that are responsible for emergency, critical, and operative care. They have some understanding of that continuity. Very sadly, there is no longer a specific position for surgery and anesthesia. The last time there was somebody full-time in that role ended in about 2018 when that individual left. And the hiring process at WHO can take like 2 years. COVID then stopped it. And now with Trump wanting to withdraw money, that position is not going to materialize. It's essentially gone, which I think weakens our voice.
Yeah.
But that should never deter one from turning up at the table and saying, hang on, anesthesia, here's how we fit in. And one can be influential. The WHO Patient Safety Group held a consensus meeting on patient safety 2030. The fact that I keep turning up there resulted in them inviting me. I'm not turning up there because they're paying anything.
Mm.
But if I'm flying to a meeting in Europe and I can spare the time, and when I was working actively clinically, if I did an extra shift, would it pay for a night and a day in Geneva. So I could just go and knock on doors and say, anesthesia, anesthesia, anesthesia. So people hear it. So I was thrilled at the end of that global agenda setting of the 5 WHO high priorities for patient safety: surgical safety, which includes anesthesia safety, and medication safety, which again involves us. So again, it's just an example of turning up. And the WFSA is the officially recognized voice of anesthesia. So we have a role there. We just need to make sure that we have people who turn up and speak up.
Now, looking at the future, what excites you when it comes to research, education, training, anything that you're seeing?
I think what excites me is the role of technology, the potential role of technology. I think that's where the action is. That's where the action has been. The technology presentation twice at this meeting, I think has very nicely demonstrated the potential. We don't know yet how that is going to work, how it's going to play out. And I am actually in the process of partnering with the Anesthetic Patients Safety Foundation in the US to do a by-invitation consensus conference immediately before the World Congress of Anesthesia on anesthesia and advanced technologies. Where do they fit in? What is their role? How do we move forward on that? So I find that potential hugely exciting. The implementation time is going to be probably 20 years. The recently released, about 3 months ago, Lancet Commission on Global Health 2050 has a nice little diagram on what have been the major contributors to the improvement of health. Far and away, technological advancement. So that's very exciting. What I find of more concern is the future of anesthesia and anesthesia training. And the fact that for many anesthesiologists, it's a very small world. It's the operating room. And that isn't any longer where the action is or where the action's needed. As I alluded to in my lecture, the majority of perioperative deaths are now post-operatively. We can keep almost anybody alive and drop them in the ICU.
Yeah.
Or in the PACU, or send them to a ward. So that's where the action is. And we as a community need to decide what is our role in that environment.
In the final outcome.
In the final outcome. And I find it very, very sad that for many of our colleagues, it's that somebody else's job. I'm in the operating theater. That is not going to be a happy future for anesthesia, because the historical imperative is somebody always takes your job.
Yep.
And so what we've made safe, others will do, be they anesthetic assistants, nurse anesthetists, clinical officers, whoever they are, will increasingly assume those roles. So we need to be training for the future. And I don't believe that a single residency is tenable in the future. And that anesthesia eventually will have to wake up to the reality that we are no different from surgery or medicine as they were 50, 75 years ago. You trained as a surgeon in 1950. You did knee surgery. You did cystectomies.
Yeah.
You did cesarean sections. You did lung lobectomies.
Yeah.
And the knowledge base and the time commitment got bigger and bigger, that they fractionated. So in my future view for anesthesia would be a very similar model, a base 2 years of the fundamentals of anesthesia, and then you become an operating room anesthesiologist with a focus on ASA 3 and 4 cases, because somebody else is going to be doing those ASA 1s and 2s. You're a critical care specialist, you're a pain specialist, you're a perioperative physician specialist, and you'll still be within the big family of anesthesia, but you'll be in other specialty groups. I don't have a sense that that is the way the current leadership in anesthesia is thinking. But I cannot conceive a future that is any different. I don't see how in 3 years, 4 years, 5 years, we can continue to play all those roles. We either need to explicitly make a decision, we're just in the operating room, and that's our small little domain. We've made it pretty safe, and we'll make it safer again, but all of the rest of the action other people are going to do. And I think the crossroads, we're standing there without realizing we're standing there.
That's a very powerful statement and a powerful look at the future, I would say. Thanks for that insight. And is there anything like a final message? This is my final question. Early career anesthesiologists. Now, this can be defined as people in training, people who have just completed the training and are in the early phases of settling down to be a consultant or a, professor level anesthetist. Any message, a personal message that would guide them to be better anesthetists, better human beings, researchers for the future?
Making somebody a better human being is a job their parents should have done. Thanks for asking. But along those lines, a couple of reminders. One, never forget you're dealing with fellow human beings. Empathy.
Yeah.
Think about what it's like. And what I tell some of our residents, which they often laugh at me, is when it's quiet in the operating room, lie down on the operating table.
Yeah.
See what it's like. See what it feels like.
It's scary.
Exactly. It is scary. That'll give you some empathy on what your patients will be doing. So don't forget empathy and sympathy for patients. Commit to lifelong learning, not just turning up once a year, listen to some lectures and leave again. Commit to meaningful learning. Take on a little project. Even if you're in private practice, you're not an academic, think about something where you think you could learn a little more. You don't quite remember from your training. Maybe it's changed. Commit to a couple of nights of reviewing the literature and making sure you're up to date. Those two things, I think, will stand you in good stead.
Thank you. That's a very powerful message for youngsters, especially with attention being the new currency, which I think the media is chugging at. So that's a wonderful message. Professor Gelb, thanks a lot for joining us. The Indian Journal of Anesthesia podcast team is in gratitude that you took time off from your busy schedule and joined us for this podcast interview. And thanks for the wonderful messages.
You're welcome. Thank you for inviting me. And I appreciate the opportunity to share my thoughts. And hopefully my thoughts, whether people agree with them or not, will prompt people to at least clarify some of their own thoughts.
Thank you. Thanks.
Thank you.
So to all our viewers and listeners, thank you for joining us and sharing your time. As we say at the end of our Indian Journal of Anesthesia podcast, stay curious and stay safe, and we'll see you in the next episode. Thank you.